COVID-19 and maternal and infant health. We know that babies come from moms, and so when we're talking about infant health, it really is talking about maternal health. So today I'm going to talk about what COVID-19 is. Hopefully you all are not burned out on hearing about COVID-19. We're going to talk about the virus, how it has affected maternal and infant outcomes, how the pandemic has affected, how the virus has affected those outcomes, and also how the pandemic itself has affected maternal infant outcomes. And then we're going to talk about the COVID-19 vaccines and pregnancy and breastfeeding. So March 11th, 2020, this date will loom in history. This is the date that the World Health Organization declared COVID-19 a pandemic. Excuse me. We had been hearing rumblings of things going on in China in December and hearing about this infection that was in Europe in December. And then in January, end of December, beginning of January, travel from certain countries was prohibited. Individuals that were living in those countries were not allowed in the United States. Then in February, I remember being in a meeting and was told you can no longer travel outside of Louisiana. I had a meeting scheduled in DC in 2 weeks following, and I was told by my institution, you are not allowed to travel outside of the state. And then March 13th, I was sitting in a parent-teacher conference at my son's school, and we got the message that the school was shutting down. And then by that Monday, the city had shut down. And so I think we all will remember going into the future where we were on March 11th and exactly what was happening at that time, because it really has changed the landscape of everything. It has changed how we communicate and how we meet. If this had been prior to March 11th, I probably would be there meeting with you in person. But now we're meeting on Zoom, and some of these things some of these changes are good, some of them not so good. But as you heard Nicole say, we have people that are on the meeting from Georgia. I'm in Louisiana, so some benefits there. But it's also changed how we provide maternal infant care in some good ways, but there's also been some challenges with that. So what is COVID-19? It feels like this just popped up out of nowhere, like we've never had anything like this before. And COVID-19 is a strain of the coronavirus. So this is the same virus that causes the common cold, severe illnesses such as SARS and MERS, which we heard about those in past years, but it's the same virus that causes the common cold. I think that's important to note because at least for me in my clinical practice, I've had patients to come in my office and I'll say, well, you sound like you're kind of sick. And they'll say, oh, I just have a cold. And I say, or you have COVID. And I think that because of what we've seen in those extreme cases, we only think of COVID as shortness of breath and severe illness, but it's really the common cold. And so anybody, in my perspective, who has a cold has coronavirus until proven otherwise. It is spread through respiratory droplets and close personal contact, which is one of the reasons that it spreads so quickly and it spreads so easily. And this is why we've had some of those mitigation things in place, masks, social distancing, because of how it spreads and how virulent it is. Now, because it is a coronavirus, it is zoologic in origin, but we have not been able to actually determine what animal coronavirus or COVID-19 has come from. This has led to some of the other theories that we've heard about. Perhaps this was not a virus that came from an animal and possibly a manipulation of a virus in the lab. But at this point, we really have theories and we have no proven really origin of coronavirus or COVID-19. Now, just to illustrate the impact. So on March 25th, and I just mentioned March 11th was the day that the World Health Organization declared COVID-19 a national pandemic. A worldwide pandemic. On March 25th in the United States, we had 29,270 cases confirmed and 349 deaths. As of October 19th, we had 45,189,652 cases confirmed and 729,885 deaths. That is, I can't even multiply that fast. That's 100-fold number of deaths in just a little over a year and a half. So this virus has spread. It has spread quickly, and it's very virulent, but it also has caused a huge number of deaths. In particular, when we look at health disparities from COVID-19, we know that there's a disparity in the number of deaths in Black and Brown individuals. So Black individuals represent about 12% of the national population, but they represent almost 23% of the deaths. So a big disparity there. And if you look at age-adjusted mortality rate, now this is as of April 15th, Indigenous people actually are the people that are the most affected by the virus, but they die at a rate 3.3 times as high as white individuals. Pacific Islanders, 2.6 times as high. Latinos, 2.4 times as high. And then for Blacks, twice the rate of whites from age-adjusted mortality from COVID-19. And in a minute, I'll talk about exactly why we see this disparity among Black and Brown individuals. Now, if we look at hospitalization rates, it mimics just what we see for the mortality rate. So Black children, 16.4 per 100,000 for hospitalization rate. Latino children, 8 times as high as that of white children, and white children, 2.1 per 100,000. And if we look at disparities, and I don't care what health disparity we're talking about, whether it be COVID-19 or if we're talking about maternal mortality, if we're talking about infant mortality, they will always have the same roots of implicit bias and structural racism. And so I'm not sure how many of you were on the presentation that I did for Wayside last week, but we went through those drivers of maternal mortality and implicit bias and structural racism and how we see that manifest in society. Well, those same drivers are the reason that we see these racial and ethnic disparities from COVID-19. If we look at those risk factors, specifically for Black and Brown people, we represent a disproportionate number of essential workers. So when everybody was told to go shelter in place, and the only places that you could go were the grocery stores and to convenience stores, who is working at grocery stores? Who's working at convenience stores? Every time I went into my local grocery store, it's the same little old Black lady that's right there at the checkout center. She didn't have an option to shelter into place. Or if I go down the street and I'm looking at our sanitation workers, if I'm looking at our hospitality workers, any of those people, they did not have that option to shelter into place because they were essential workers. We know that in Black and Brown communities, we have decreased healthcare access. So because of this decreased healthcare access, we are disproportionately we have a disproportionate rate or represent a disproportionate rate of individuals with hypertension and diabetes. And we represent a disproportionate rate of uncontrolled hypertension and diabetes. The two leading causes or the two associations or health risks for having a maternal or having a mortality from COVID-19. And so these are, as you see, these are systemic and historical conditions because of structural racism that are now coming out and manifesting in these different health disparities. We have decreased access to high quality education, which then affects our ability to get those non-essential workers, that employment as a non-essential worker, because we have that decreased access to high quality education to be able to be those white collar workers that were able to shelter in place when that was called for. We have crowded housing. Some of that is by design. Some of it is, again, because of the systems that have caused economic suppression. Black and Brown people are more likely to live in multi-generational households. Again, some of that is by design because we choose to do that. We choose to take care of the older members of our families by having them live with us or us live with them. But some of that is because of the economic instability and the need to live in multi-generational households. So, and if you're in a multi-generational household, especially in a small space, if one individual in that family has COVID-19, how does that person social distance from everybody else when you're talking about a 900 square foot apartment? And so again, these are how these systems have affected our social determinants of health, which then predisposed our susceptibility to COVID-19, as well as the outcomes that we see, the mortality rate. In addition to crowded housing, as I mentioned, we have economic instability. So again, as essential workers, one, we don't have the option of staying at home. And two, if we stay at home, then we don't have money to buy our essentials, to buy the things that we need. When they said shelter in place and everybody goes to the grocery store and they are racking up and stocking up on food and things of that nature, if you're living check to check, you don't have the ability to stock up on anything. And so that economic instability is, again, another social determinant of health through systems of racism that then make us, again, more susceptible to COVID-19. And then, of course, we have implicit bias in care. If you remember when COVID-19 first emerged, the 3 symptoms that you needed to have was cough, shortness of breath, and a fever. So if you go to the emergency room, only one of those is an objective measure, and that's a fever. Cough and shortness of breath is still very subjective. How short is short of breath to say you need to be hospitalized? How deep of a cough, or how many times do you need to be coughing to say that you're coughing enough to be hospitalized? And we know there are many cases of Black and brown people going to the emergency room with symptoms of COVID-19 and being turned away, and then later experiencing that mortality at home because they were not hospitalized and getting the oxygen that they needed. And then if we look at COVID-19, then the Delta variant came around, and then we were on a completely different playing field. So just to speak about the Delta variant in particular, or about variants in particular, viruses constantly change and they mutate. This is why we have to get a flu vaccine every single year, because by the time the next year has come, the virus has already mutated. And so we need to do another vaccine. And so COVID-19 is not any different. What happens is viruses find a host, and when they're their host, they mutate. Some of those variants are not as virulent and they don't survive and they die off. And if you remember, we heard about the UK variant, we heard about the South African variant, we heard about the Indian variant, and very responsibly, the World Health Organization, in a matter of trying to maintain equity and prevent bias, decided to stop calling the variants based on where they were first discovered, but started this nomenclature of going down the Greek alphabet, alpha, beta, gamma, delta. Because as you know, there's been a lot of bias towards Asians because many people called COVID-19, the novel strain, they called it the China virus. And that caused a lot of bias towards Asians, especially Asian Americans. And so the World Health Organization was did the right thing in starting to name these variants by the Greek alphabet. And so there was the alpha variant, which we probably didn't hear much about, and the beta and the gamma, those died off. There's even a lambda variant that's come after Delta, which is not as virulent. So it's not infecting people in the same way. And so it's gone away. And so there are more virulent variants like Delta. And so Delta spreads more easily than the previous variants, and it may cause more than 2 times as many infections. So if you look at the picture here and look on the left side, you can see if one individual is infected, they're likely to infect 2. When we talk about Delta, because it is so virulent, you don't have to be exactly in somebody's close proximity for more than 15 minutes, or that we thought before. They can be further away for a shorter period of time. And that one individual that's infected with the Delta variant can infect as many as 5 individuals. So this is why we were seeing the spread and why we had our 4th surge. And really the solution is vaccinations. And I'm going to talk a little bit about vaccines themselves. Oops, excuse me, just a second. I'm going to stop my slideshow because I think I may have gotten my slides out of order here. If you'll give me just a second, I apologize, because I want to tell you more about the vaccine itself before we start talking about specifically about pregnancy, although that is a very important part of this, especially when we talk about our maternal and infant outcomes and just what we've seen about COVID-19 in pregnancy, as well as COVID-19 and the vaccine in pregnancy, all of those things. Give me just a second. All right, I think I have things in the right order here now. I'm gonna stop sharing and then restart this slideshow. If I can get it to start. Okay. Get my Zoom controls. Okay, I apologize for that. I was adding some things to the slide just as we got ready to start talking, and I must have flipped things around. And so one of the things that we've seen when we talk about the viruses and the vaccine, because again, we talk about how did the virus affect maternal infant health and health in general, but also how did the pandemic itself affect health and affect our outcomes? Well, we know that because of the pandemic, there has been an effect on ambulatory care. So we have decrease in preventive services such as breast cancer, cervical cancer screening, STI. When we were sheltering in place, we as providers were told we could only see those patients for urgent visits. So that meant no mammograms, no pap smears, no screening for sexually transmitted infections. Even for some obstetric care, no in-person obstetric care. And what it has led to is the increased use of telehealth. And so one of the things at my institution, we had a telehealth program prior to the pandemic called Connected Mom. And in Connected Mom, moms get a blood pressure cuff, they get a scale, it's free of charge, they don't pay anything for it, the hospital pays for it. And it takes those vital signs, it uploads it to their electronic health record. We use Epic, but it uploads their electronic health record through the Bluetooth device connecting with their smartphone. And with that, then we also have the component of doing a telehealth visit, which is almost like FaceTime or like the Zoom that we're doing now. So like I said, I was in my son's, I said the 13th, I was in my son's, oh, it was the 13th. I was in my son's parent-teacher conference on Friday, March 13th. And by Monday, I had flipped all of my patients to virtual visits so that they could shelter in place. Now, again, that's great because they were able to shelter in place. I was at the hospital, but I was able to keep them from coming out of their home and risking being infected. I know it feels like this was years and years ago, but this was just a year and a half ago when this first emerged. We really didn't know very much about it. We just knew it was spread through respiratory droplets and everybody just needed to stay at home. And so by doing telehealth, we were able to do that. Now, the flip side of just as we've seen this decrease in preventive screening, and there's data to show this for breast cancer, cervical cancer, and STI, the data has not been published, but we also saw a decrease in things like screening for gestational diabetes, screening for group B beta strep, all of the other routine screenings that we would normally do in OB care, where individuals would have to be in person, all of that decreased as well. So again, not only did the virus have an effect on moms, on babies, but also the fact that there was a pandemic in general and not being able to get access to care. And so moving on from there, so where are we now? What is happening and where are we gonna go? And so vaccinations really are the beginning of the end of this pandemic. I have this slide up right here with this particular picture because, as I mentioned, I'm in New Orleans, and New Orleans is known for a lot of things, but the biggest thing that we're known for is Mardi Gras. And it was unheard of. It's only happened one other time in history. To think that we would not have Mardi Gras here in New Orleans. And we didn't last year. The mayor did cancel Mardi Gras because of the pandemic. Now, I think our rates got so high in New Orleans because of Mardi Gras in February of 2020, but in 2021, Mardi Gras was canceled. And that is just so much of our identity here in New Orleans. In Louisiana in general, but particularly here in New Orleans. And it's something that I thought would never happen. I never thought there would be a time that we would not have Mardi Gras. But now that we do have vaccines and we're seeing our rates go down, there is a plan for us to have Mardi Gras in 2022, if anybody wants to come visit. So why are vaccines the beginning of the end? Well, there's something called herd immunity when we do vaccinations. So you can see on the left, when we don't have herd immunity, that one infected individual infects another individual, and that individual infects 2 more people, and those individuals infect 2 more people, and this is how we have the spread. When we get to herd immunity, which Dr. Fauci has said is going to be about 75 to 80%, and we're not there yet, but when we get to herd immunity, that infected individual, if he or she has all these immune individuals around him, that's him or her, that stops the spread. And so there's 2 ways to get a herd immunity, either natural infections or effective vaccinations. Now, natural infections, we know with COVID-19 means an increased risk of death. And so a natural infection is not the way that we want to get to herd immunity. Not to mention that when you are infected with COVID-19, based on some of the data that we know, your antibody response is not as high as someone that's actually gotten the vaccine. And so this is really why vaccines are the way that we get to the end. Now, just to talk about the vaccine and how it works and how it was developed. So the Pfizer and the Moderna vaccines use mRNA or messenger RNA, and Johnson & Johnson uses a viral vector. Now, there is no live virus in the vaccine. And so when someone is getting vaccinated, they're not getting infected with COVID-19 because there is no virus there. As I explain to people when I'm trying to explain what messenger RNA or mRNA is and the viral vector, like how does that work? It's almost like someone walking into your body with a flag, a red flag. And this individual says, every time you see this red flag, antibodies, I want you to attack anybody carrying this red flag. And then he leaves. And so that's what messenger RNA does. And what the viral vector does is it brings in that spike protein so that when your body sees the spike protein again, it already has its soldiers ready to go and attack the infection. Messenger RNA, this technology is not new. Yes, this is the first time it's been used for a vaccine, but it has been in development for the last 10 years. And in fact, the lead researcher that helped develop the messenger RNA vaccine for COVID-19 is a Black woman and with NIH, and has been working on this technology for a very long time. Again, once the protein is created, it triggers that immune system to produce antibodies and to destroy that spike protein. And so now the immune system has learned how to recognize and fight COVID-19. Now, and I'm going to tell my vaccine story in a minute, but it's important to understand that when vaccines are developed, there are different phases. So phase 1, they first give it to several hundred volunteers, or 20 to 100 healthy volunteers. Phase 2 is several hundred volunteers. And then phase 3 is thousands of volunteers. So all of these phases happen for the COVID-19 vaccines, just like they do for every other vaccine. There is an authorization process. And I think this is, even when I was talking to my husband, he was just saying how confused he was as to whether or not we were even supposed to get a booster. He said the FDA approved it, so why aren't we supposed to get a booster? There is a process for when vaccines are authorized. So first, vaccines go through that whole process of being created, being tested. Once that information is all gathered, then that's given to the FDA. And then the FDA says, okay, we have looked at this. This vaccine is safe and it's effective. Now, to be effective, it only has to be 50% effective to say that it is an effective vaccine. And you'll remember, I'm sure from hearing in the news, that that Pfizer and Moderna are 95% effective, Johnson & Johnson 85%, because it was developed a little bit later once the variants were around then, so 85% effective. But that is the role of the FDA. And the FDA does this for every single medication that we use, every single machine that we use, every vaccine, medical device, all of those things. That is the role of FDA. Once the FDA says, yes, it's safe, it's effective, then it goes to the Advisory Committee on Immunization Practices, or ACIP. And so they then make recommendations on who should receive each vaccine. And then that goes to the CDC, and the CDC makes the final recommendations on prioritizing who receives the vaccine and when. So that is why, yes, the FDA said boosters are safe, but then the CDC is the one that says 65 years and older should get it. 18 years old and older if you work in healthcare or if you work in a high risk situation. And now we're going back through this because Pfizer has now given the FDA information and asking the FDA to approve the booster for everybody. And that still will not happen. If the FDA approves it, it still will not be approved for everybody until the CDC signs off on it. So just a little bit about the process. Also understanding that this is all of this is what's involved in the process. There are a lot of steps along the way to make sure the vaccine is safe and it's effective. So there have been no deaths in the United States proven to be caused by the COVID-19 vaccine. But as you saw before, there have been more than 700,000 people that have died from COVID-19 itself. And so I think that's important to understand, relative to the vaccine itself. So side effects from the vaccine, we call these side effects, but they're not really side effects. They're really your body's immune system responding. And so you're supposed to have some of these things. The only thing I would say that really is a side effect is maybe the pain at the injection site. But fatigue, headaches, fever, chills, joint pain, all of that is your immune system reacting. And so it's doing exactly what it's supposed to do. So some may experience, as y'all probably know, mild fever, soreness, muscle aches, chills, fatigue, all of these things. Again, signs that the immune system is responding. And these side effects don't mean that you have COVID-19. As we already mentioned, the vaccine is not a live virus. And the symptoms usually resolve very quickly. There are allergic reactions that can happen, including anaphylaxis. And those are very, very rare. There were 50 cases of anaphylaxis out of 10 million doses of Pfizer, and then 28 cases out of 7.5 million doses of Moderna. So again, very, very, very rare. Now, with Johnson & Johnson, there were some negative things that came up. There were 6.8 million doses of J&J administered, and 6 patients, and that may have gone up to 11 patients, had a rare and severe blood clot reported in the venous thrombosis. And so what happened when that took place is that the Advisory Committee on Immunization Practices and the FDA stopped administration of Johnson & Johnson so they could look in more detail to see if this really was happening because of the vaccine. I put this in place just so individuals understand that even after the vaccines have been approved, there are still a lot of bodies that are overseeing, regulating, and monitoring to make sure that the vaccines are safe. So we should have all comfort that the vaccines are in fact safe. Now, just to tell you my vaccine story, I would remember when we were hearing in the news that they were working on a vaccine and working on the vaccine for COVID-19. And my patients would ask me, what do you think about that? And I was like, oh, well, I think everybody should get the vaccine and I'm going to see what happens. I don't know about that. I think this is just too quick. My perspective had been that of someone that had participated in clinical trials and as a principal investigator. And when I was in these clinical trials as the principal investigator, it took us, and it was for a medication for treating heavy menstrual bleeding associated with fibroids. And in these clinical trials, I'm going to stop sharing just so you can see my face as I speak here. But in these clinical trials, we had to do this for about 5 years before the vaccine was approved. Before the medication was approved. And so for me, I could not understand how a vaccine would be approved so quickly if we had to do our testing and do our data for over 5 years. And so I, at that time, was not in favor of the vaccine. I did not understand how it could be proven, how it could be safe if it just didn't go through all those steps that we had to go through. And in reality, the vaccine had gone through all the steps that our medication had gone through. It just happened in a way that was where the steps were all on top of each other. So ours had been phase 1, then phase 2, then phase 3. And phase 1, we stopped and they did some research, and phase 2 and stopped and did research. Whereas the COVID-19 vaccine, the steps were done on top of each other, but all of those steps were done in the same manner. So I felt a little bit more confident when I heard that. Then I happened to be on call and I got a message from Oshner that said, it's your time, and it's time to get my vaccine. And I wasn't sure that I was ready for it to be my time. And so I was still thinking about it and going through the data, going through the literature. And the first 2 patients I had that weekend on Saturday and Sunday, the first 2 patients were pregnant patients that were positive for the virus, asymptomatic. Because at that time, we were screening all patients that came in the door that were being admitted to see if they had the virus. And it occurred to me, I'm going into a delivery and I have on a mask, an N95, I had on gloves, a hat, I had on a gown, I had on a second gown, I had on boot covers. I was covered. I was protected. And so it occurred to me as I was going in all this protection, that while I was protected and I did not feel like I was going to get infected while I was delivering this same patient was sitting in somebody's office 2 days prior with COVID-19. And that individual, that provider, was sitting there with just a mask on her face or his face and exposing themselves. And so it dawned on me how much I was being exposed being in the clinical setting, because we knew at that time the asymptomatic rate was about 30%. And so it occurred to me how much I was exposed and how much I was then taking a risk of not only getting infected, but also bringing that home to my husband and to my son. And so after I looked at the literature, realized my risk, then I made the decision to get vaccinated. And I think it's important that we as providers say that and think about that, because I think that I am obviously, as I'm speaking and is the recommendation, I do advocate for the vaccine, but I think it's important for individuals to understand our story and what decisions we had to go through to decide to get vaccinated. It wasn't just that I jumped on the bandwagon. So now talking about COVID-19 and pregnancy. And so we know that the vaccines are safe. We have the CDC V-Safe registry data. And so as of September 13, there's over 150,000 individuals in the V-Safe registry that are identified as being pregnant at the time of vaccination. And there's a separate pregnancy registry data with over 5,000 patients. There have been no increased risk in complications or adverse events, and side effects are similar to the non-pregnant population. And I'll talk about that in a little bit more detail in just a second. But if we look at COVID-19 itself, what do we know happens for maternal risks? So for COVID-19 and pregnancy, those individuals are at a higher risk of preeclampsia, admission to the ICU, need for mechanical ventilation, and death. And they're at high risk of severe illness if they have comorbidities. We also know that they're at increased risk of preterm birth. And so we know what that means for our infants. And then if we look specifically at even preeclampsia, they've done studies that showed even for asymptomatic positive patients, they were at a higher risk for maternal morbidity and preeclampsia. The relative risk for preeclampsia was 1.76 compared to 1.6 in the asymptomatic patients. And then 4 times greater if they had a comorbidity such as being overweight, diabetes, having hypertension. Their risk of admission to the ICU is fivefold. And we now know that COVID-19 during pregnancy is strongly associated with preeclampsia, especially among nulliparous women, independent of any risk factors or pre-existing conditions. So just having COVID-19 alone increases the risk of preeclampsia, which then increases the risk of maternal morbidity, infant mortality. And then again, for infants, when mom is infected with COVID-19, there's an increased risk of preterm birth. There is, most of the time, those babies are admitted to the NICU because of preterm birth, and they stay 7 days or longer. And then there's a 10 to 12% risk of the neonate testing positive when the mother tests positive. Now, it's not because the neonate is getting it through vertical transmission or through the delivery itself. It's that mom is getting it, mom is holding baby, and then because of that close contact, then baby is getting it through respiratory droplets. But again, that increased NICU stay is the longest for a positive mom and a positive baby, but it's also higher for a positive mom and a negative baby compared to a negative mom and negative baby after you adjust for preterm birth alone. And so again, definitely affecting our infants, even if mom tests positive and baby tests negative. And then when we look at that, the VSafe registry data going back to the vaccines, if you think about the background rate of any of these things happen in pregnancy, gestational diabetes, preeclampsia, eclampsia, IUGR, preterm birth, congenital anomaly, if you look at the background rate, and then you look at the rate on the right side, I don't know if y'all can even see my cursor, on the right side over here for those individuals that have gotten the vaccine, you can see it's pretty much the same. So there's no increased risk of gestational diabetes, preeclampsia, eclampsia, IUGR, preterm birth, anomalies, neonatal death, any of those things if you get the vaccine. But all of these things we know increase your risk of having a severe complication, or they themselves are at increased risk just from contracting COVID-19. And then one more thing about the vaccine, when moms get vaccinated, they protect their baby. So we know from a study that was done at Harvard, they pulled the umbilical cord blood for moms that had COVID-19 and moms that were vaccinated, compared the two, did the same for breast milk, and the antibody rate was higher for those moms that got vaccinated. And those antibodies were in the umbilical cord, which means when mom gets vaccinated, she passes immunity to the baby through the placenta. And so we know it's a long time before babies are going to be able to get vaccinated. And so mom is able to give their baby that bit of protection when she gets vaccinated during the pregnancy. And we also know that there are antibodies in the breast milk. So if mom gets vaccinated during the pregnancy, she is passing those antibodies through her breast milk as well. Now, even with all of that being said, we know that the vaccine is safe. The American College of Obstetricians and Gynecologists, Centers for Disease Control, World Health Organization, the Society of Maternal Fetal Medicine, all not only say that it's safe, but they recommend the vaccine in pregnancy. In fact, as an obstetrician, I am to document that I'm offering the vaccine. And if a patient is not wanting to get it, I am to document that they declined it. And so they are really recommending it. But even with that, our vaccination rates amongst pregnant individuals is only about 30%. There was actually an article in the Wall Street Journal last week that I participated in and had a quote in about this, that the vaccination rates among, like I said, pregnant individuals is about 30%, but only about 16% in Black individuals. And if we think about that and we think about why, part of the reason from my perspective is we have throughout our history of research and medicine, we have not been ethical in the way that we do research for Black individuals. And so there is a distrust of the healthcare system. There's a distrust of research. And so I think there is a distrust among Black individuals in general about the vaccine. I think that's one part of it. And then we also know from looking at data that Black individuals are less likely to be offered the flu vaccine during flu season. And so it makes me question, if that's already the case with the flu vaccine, how much are providers offering the COVID-19 vaccine to Black pregnant birthing persons? And so in summary, the COVID-19 pandemic has disproportionately affected Black and brown people. As with all health disparities, implicit bias and structural racism are at the root. And really, vaccines are the beginning of the end of the pandemic. Vaccines are safe for pregnancy, but vaccination rates remain low, especially among Black pregnant individuals. And we all are ambassadors for change. I posted my story about getting my vaccine. When I got the first vaccine, I posted it on Facebook. The hospital was going to post it anyway, but I posted it on my Facebook page. And I did not expect some of the responses that I got. Some individuals that I went to high school with told me, you know, I wasn't going to get the vaccine because I felt like the government was pushing it. And I don't know those people on TV that are saying that we should get it, but I know you and I trust you. So if you felt like it was the right thing to do, I'm going to reconsider. And so each of us has people in our circle that are doubtful about getting vaccinated, or people that we take care of that are doubtful about getting vaccinated. And so we all have that ability to give them the information so that they can make the decision for themselves, but to make sure that they're using good information to make that decision. And in the time that I have left, I'm happy to answer any questions.
Wonderful. Thank you, Dr. Gillispie. I really appreciate your transparency on your vaccination experience. I see you are wearing your green and pink. I'm a Sigma Gamma Rho, so it is great to see that. We are now able to take any questions. You can place your questions in the chat, and I'm also sharing the link for the upcoming series. Right now, I don't see any questions. I know I had one question, curiosity, and I've listened to a lot in the research, and I took Johnson & Johnson. I have lots of allergies, and I too was very apprehensive in the time period. So do variants come based on the host, or do they just mutate on their own, or is it environmentally also a contributing factor in how they mutate in a hotter climate or a colder climate? Are any of those things a factor?
So that's a great question. As far as we know, so viruses are really smart. Viruses are very smart, and they are here just to survive. And so what they do is they're like, oh, okay, well, I can't survive like this, so let me change. Let me see if I can survive like that. And so, but they can't survive on their own. They have to have a host to be in. And that's why vaccination is so important, because the more hosts that are available, that gives them more time to keep surviving and figuring out how to be smarter and to mutate so that they don't die. And so it doesn't seem to be environmentally related. I know that was one of the things that was proposed when the virus first came out in the winter. They were like, oh, and when it gets to be summertime and it's hot, then the virus is just gonna die. Viruses are so much smarter than that. So then they figure out how to survive. Now, if they don't have a host to live in, then they're just gonna die off. But as long as they have a host to live in, then they learn how to be smarter and how to survive. And that's why too, that's why boosters are needed right now. Because when the virus first came out, and I just lost my train of thought. But when the virus first came out, and we were all getting vaccinated, or some people were getting vaccinated, then the virus, you know, for those individuals that did not get vaccinated, the virus went into those individuals and learned how to be stronger and how to be smarter. And we knew we were going to have breakthrough rates, like that people that were vaccinated were still going to test positive and, you know, have mild symptoms, but it was much larger. The percentage was much larger than was anticipated. And it's because of the Delta variant. And it was because it was able to mutate and be so much more virulent, we had more breakthrough infections. And again, that's why now we need the boosters. It seems to be more of that than our immunity kind of waning off, but more so because now we have these variants.
Okay, thank you. I don't see, I'm going to ask again if anyone else has a question. Please place it in the chat and we'll be happy to get an answer. I'm just really curious about what the future looks like, where naturally the medical profession, you're knee deep or neck deep, right? And updates constantly. I'm just wondering, what does this mean? Because, okay, I've got friends, we're all vaccinated now, right? We still are being caring, and we still, many of us still wear a mask around each other. Even if we're coming together, we're still safe, and being thoughtful. But now I notice some of my friends are getting these really ugly colds that are lasting like a week. And so we're all like, okay, is it COVID, you know? And so just the balance of being vaccinated and understanding, okay, yes, we're still going to have a flu season or common colds that seem to be stronger right now.
Yes, so you hit on a bunch of points, and I could talk for days, but you know, so there's a few things because we sheltered the bad part, because we sheltered in place and we've had on masks and all of these things. We've not built up any natural immunity to the regular common cold because we were, you know, we built up natural immunity when we were exposed to viruses, and we missed that. You know, we missed that. It's been 2 years now, believe it or not, that, you know, almost 2 years that we haven't had that immunity to build up. And so there is a concern that things like the common cold that we may have gotten over a little bit quicker, we won't, because we haven't built up any immunity towards it. So there is that part of it. I think this is my opinion, not necessarily data is out, not because it's published in anything. This is just my opinion. As far as the future, I would not be surprised. I would not be surprised if we have another surge in December or January. I am praying that is not the case, but would not be surprised for a couple of reasons. One, we tend to, in the United States, follow the trends of the European countries, and the European countries are having a surge, like they're shutting everything down again. We usually fall like 2 or 3 months after them, we have the same thing. So that's one part. I think because we've gotten much better with vaccination rates, we are easing all of our restrictions. So I know for us, like they have lifted the mask mandate here in Louisiana. The governor has lifted it because our numbers are going down, which is great, but we're still not at herd immunity with our vaccination rates. So we are still susceptible to the virus. And so again, I am hoping this is not what happens, but I would not be surprised if December, January, we have another surge. In terms of something I didn't really talk about, but in terms of the healthcare system itself, we are at the brink of breaking right now. We are so backlogged on surgeries, on procedures and things like that, because we've had to shut down so many times. I have patients that I have had to reschedule their surgery 2 and 3 times because, and then in Louisiana, we had a hurricane as well, but we had to shut down because there was a surge. Then we started booking again. We had to shut down again because of the 4th surge. And again, here in Louisiana, then we had the hurricane. So now we're trying to catch up on all those people that we were supposed to operate on. Plus everybody is still sick, still has problems. So they're all coming in. So we're trying to catch up and keep up at the same time. Same thing for preventive services, because for me as an OBGYN, all these women miss their pap smears, miss their mammograms because we had to shelter in place and could only do urgent things. So we're trying to keep up with current, make up. And we have a shortage of providers, especially nurses, medical assistants, surgical techs, they just didn't come back to the workforce. And then we have a large number that have decided to not be employed because they do not want to get vaccinated. So as a healthcare system in the United States, we are teetering on the brink of coming apart.
There is one important question I want to get. I know we got a couple of minutes, and the person is asking about the hesitancy of those who are thinking about future pregnancy and being worried about reduced fertility as time passes. And I know that's been a great concern.
That has been a great concern, and I did not include it in the presentation today. And I apologize. And maybe I should have. So there have been no There's been no data, nothing to show that the vaccine causes infertility. I wanted to know where that rumor came from, so I did research. So there was a researcher, a Pfizer researcher, that did a what if theory. He said, what if the spike protein in the vaccine causes an immune response that will then go and attack the spike protein on the syncytial trophoblast, which is a part of embryology and implantation and all of those things. He did a what if. Researchers at Yale did 3,000 permutations and did not see this reaction take place. However, the myth was already out there. There have been other studies to show that as well. So in vitro fertilization specialists, and if you don't know about in vitro fertilization, when someone is going through IVF, the doctor has given the mom medications, retrieved those eggs, taken the sperm, put the egg and sperm together, put the embryo in the uterus. In that case, the only thing that needs to happen is implantation. So they looked at fertility rates of implantation for those individuals that have been vaccinated and those that have not been vaccinated, and fertility rates were the same. So this vaccine did not cause the proposed, antibody that would attack the syncytial trophoblast. My mother-in-law sent me something on Instagram, not because she believed it, but just because I'm a gynecologist, that said that if you sleep with a man that has gotten vaccinated, his sperm will make you infertile. This has also been tested. They've done the semen analysis and looked at the parameters for those men that have been vaccinated. Well, they looked at it before vaccination and they looked at it after vaccination, and the parameters did not change. So this myth has been completely debunked. There is nothing that shows that the vaccine causes infertility. Again, once a myth is out there, it's real hard to bring it back in. But there's nothing out there that supports that it causes infertility.
Wonderful. Thank you so much. Right at 12:59. Dr. Gillispie, I don't know about everyone else, but you have made me feel like you're a local doctor. I'm old enough where the doctor was at the end of the corner of our street, and you've made this very personal, easy for us to understand, and very transparent. And although you're in Louisiana, we feel like home. So thank you so much for your wonderful work, and we will keep you lifted up with positive energy.
Thank you so much. My pleasure. I hope to maybe in 2022 come and see y'all in person.
Yes, we want a conference. We're hoping in the near future we can plan a conference, but we appreciate you so much. And I know Keisha's on. I want to just thank you. I've enjoyed working with you, and we wish you the best. And thank you for all the attendees and to Minnesota Department of Human Services for making this possible. Have a great afternoon, everyone.
Thank you so much.
Thank you, Zora. I'm gonna stop this recording.